All right, I see we have more and more people joining, so I'm going to go ahead and kick us off. Thank you for joining us for this first webinar in the NARS virtual conference for this year. We'll be talking about the very important topic of addressing substance use disorder in the human services context. We've got a lot of different interesting cross-system perspectives, and I think we should have a great conversation. So I want to start with a few webinar housekeeping reminders from Kayla Thompson in Apps IT department. And then Lauren Antello, who chairs or co-chairs the NARS Virtual Conference Planning Committee, will talk a little bit about NARS and about the virtual conference. And then I'm going to provide a little bit of framing around the issue we'll be discussing today, and then we'll move on to our moderated discussion and have plenty of time for Q&A. So Kayla, I'll go ahead and turn it over to you.
Thanks, Hannah. Like Hannah mentioned, my name is Kayla Thompson, and I will be tech support for this webinar. And before we begin, we'd like to review a couple of housekeeping items. First, please note that this webinar is being recorded and will be made available after the event. All attendees will be muted for the duration of the webinar. However, we anticipate and hope to hear from you during the session. We ask that you please submit all questions and comments for today's panelists into the Q&A feature in WebEx. If it is not already open on your screen, you can open the Q&A by clicking the three dots on the lower right-hand corner of your screen and then select the Q&A option. Additionally, there are two recommended ways to connect to audio: computer audio or through the Call Me feature in WebEx. To switch your audio connection, please click the drop-down arrow next to the mute button, then select Switch Audio and select your preferred audio option. You can switch your audio connection at any time during today's session. Finally, if you have any technical difficulties during the webinar, please feel free to submit your question or concern to the Q&A feature, and we will be happy to assist you. That does it for my tech notes. I will now pass it to Lauren to get us started.
Thank you, Kayla. So my name is Lauren Antello. I'm a senior advisor at the U.S. Department of Health and Human Services Administration for Children and Families, and I'm also the co-chair of the NARS Virtual Events Committee, and I'm so pleased to welcome you to Addressing Substance Use Disorder in the Human Services Context, Cross-System Perspectives. As Hannah mentioned, this is our inaugural session of the 2022 NARS Virtual Series. NARS stands for the National Association for Welfare Research and Statistics, and we're a nonprofit association whose purpose is to promote the exchange of ideas on how research and statistical analysis can contribute to the development and administration of effective human services programs. We hold in-person conferences every other year where human services researchers, practitioners, and policymakers come together to talk about their work and how it can inform policy and practice. Several years ago, we began holding virtual events in the years when the conference wasn't occurring, and they represent an opportunity for us to keep the community engaged and highlight interesting research and trends that are relevant to the membership. You can sign up for a listserv at nars.org or follow our Twitter feed at NARS Workshop to learn about upcoming virtual events later this summer. We have a couple more planned, including what the COVID era changes in the economy and labor market mean for TANF programs and the families they serve. The second, engaging community voices in policy, programs, and research. And lastly, assessing the impact of the pandemic on child care market and women's labor force participation. So on behalf of the NARS board, I want to thank Hannah Batesh of Apt Associates, a member of our virtual events planning committee, for her leadership in designing and facilitating this session. I want to thank my co-chair of the virtual committee, Asaf Glosser of MEF Associates, and a particular thanks to our panelists for their willingness to share the expertise they bring to this important topic. I'll pass it back to you, Hannah.
Great, thanks, Lauren. Yes, so we're very lucky to kick off this first webinar in the virtual conference with a wonderful panel today to talk through the topic of how to address substance use disorder in various human services contexts. So Chief Penelope Sapp from the Kitsap County, Washington Sheriff's Office will talk about her work in the criminal justice system. Alice Worrell from the Ohio Department of Job and Family Services will talk about her work in the workforce development system. And Jay Wersher from the Oregon Department of Human Services will talk about his work in the child welfare system. All three of these panelists have done some really interesting cross-system work as well and can tell us more about that. First, though, I want to provide a little bit of framing on the issues that they've been addressing in their work. So I want to start by talking about the challenges in addressing substance use more broadly, which have ramifications for all three of these systems: criminal justice, workforce development, and child welfare. So first, we've seen huge increases in a range of substance use indicators, things like drug-related hospitalizations as well as overdoses. Overdose rates specifically have more than tripled since 1990, but we're also seeing an acute rise even just in the last few years. So in 2021 alone, overdose deaths increased over 20%, totaling more than 100,000. So the challenge here is obvious. The scale of the problem is large, and then it also continues to grow. Second thing I want to point out is that people who need treatment for a substance use disorder often can't access it, both accessing treatment generally and also access specifically to medications for opioid use disorder. Almost 21 million Americans have at least one substance use issue, but only 10% of them can receive treatment. And then third, the social determinants of health matter enormously. So substance use is widespread, but the challenges that I just noted are heightened by structural barriers. So for example, treatment options and access to providers who can prescribe medication for opioid use disorder are going to be a lot more limited in rural communities and in underserved communities. And even where treatment is available, it can be difficult to find family-friendly treatment options for parents and to find culturally responsive treatment options. So all these issues affect the daily work of human service agencies. And then I also want to talk through the specific ways these issues show up in each of the systems that our panelists work in. So for the child welfare system, most substantiated abuse and neglect cases involve substance use by a custodial parent or guardian. And over the past 2 decades, removals resulting from substance use have nearly doubled. Nationally, rates of drug overdose deaths and drug-related hospitalizations also have a statistical relationship with child welfare caseloads. So rates of Child Protective Services reports or substantiated reports or foster care placements are correlated with rises in rates of drug overdose deaths and drug-related hospitalizations. Generally, counties with higher overdose death and drug hospitalization rates also have higher caseload rates. And in addition, those substance use indicators correlate with rates of more complex and more severe child welfare cases. In the workforce development system, rates of opioid-related hospitalization and overdose deaths are higher in geographic areas with high rates of poverty and unemployment, and the long-term unemployed are particularly affected by opioid use disorder, and including hospitalization and overdose death rates. And people who are unable to find employment are more likely to relapse than those who are employed. In the criminal justice system, almost 2/3 of people who are currently incarcerated in the US have a substance use disorder, and people who are leaving jails and prisons are more likely to die of an opioid overdose than the general population, and the risk of that is the highest in the month after release. Access to treatment for substance use while incarcerated can reduce the risk of recidivism. So there's ramifications for all three of these systems. And so with that background, I'm eager to hear from our panelists on 3 discussion questions. So I will pose those 3 questions. Each panelist will have about 4 minutes to answer each question. And as you in the audience come up with your own questions, please enter them in the Q&A boxes Kayla mentioned so that we can pose them to panelists when they've answered the 3 questions that I'm about to ask. So for our first question, I wanted to ask, how does substance use disorder impact your system and the families you serve? What are the main challenges for service delivery? Jay, would you please start us off?
Sure. My name is Jay Wersher. I work in the state of Oregon, and I'm biased about this issue. I've been an addictions counselor for 42 years, and for over the last 20, been involved in the child welfare system. I have a kind of a unique job in that I am the alcohol and drug guy for the Child Welfare Office, which is something I certainly recommend for all state agencies, is to find your own A&D person, because this issue is overwhelmingly the biggest issue in child welfare, and nothing's even really close. And thinking about research and statistics for us, about 3 years ago, right before COVID hit, our research people did a case file read where we literally looked at 1,000 cases, specifically cases where children had been removed. And we found that 75% of the kids who ended up in foster care had at least one parent with a substance use disorder. That number kind of shocked people who weren't caseworkers, because anecdotally, we had talked to caseworkers for years, and some of the ways we collected statistics, we'd come up with 50% numbers and 40% numbers, and all of our caseworker feedback was, that's crazy. I sometimes don't have any cases that aren't substance use disorder cases. So we really felt great about really nailing this through a case file read, that it's a 75% figure, and everybody knows that that's pretty accurate. The other thing that was surprising to some people is when we looked at child welfare cases that had domestic violence as a major play, 87% of our child welfare cases where domestic violence was a factor also had substance use disorder. So domestic violence typically doesn't run by itself, it runs in tandem with substance use disorder. And what that means is that the caseworkers that we have to constantly, if they're cutting edge, be approaching every conversation with those parents through the lens of knowing this person has a chronic illness that can kill them. When you think about an illness that is taking people out at the rate about 1 every 6 minutes, our parents are aware of that at some level. And yet we kind of approach conversations and we want to engage people. And the topic becomes much more serious than I think workers can wrap their brain around. We have a really dedicated force of child welfare caseworkers that are focused on the child, on the safety of that child, on what needs to happen for that child. And yet most of our conversations are with a parent. So what we have to do is make sure that our workforce can really talk through the lens of that substance use disorder, because again, it's overwhelmingly the biggest issue that we have to deal with. And in regard to the second part of the question, and Hannah, do you want me to move on to that part? The main challenges for service delivery are kind of threefold. The first one is worker training. And what I want to say about the challenges for working with people that have a substance use disorder, the old style of this is your brain on drugs, and you'd see the video of the egg in the frying pan. That's useful information in terms of knowing what methamphetamine does to the individual and what opiates do to the individual, because there's huge drug variations. But the primary issue, the most important training item, is to know how to talk to people with this illness and how to make sure they keep in mind that it is an illness, because no matter who you are, and I've been doing this for a long time, it gets really hard to look at the behaviors of people with substance use disorder. They do illegal, immoral, unsafe, crazy, stupid things. That's part of the illness. And so as human beings, we start to react to the things they do rather than the illness they have. So the challenges for service delivery are, it starts in our building. We have to understand what this illness really is and how it plays out. Then we have to have all those linkages with local treatment programs. We're pretty fortunate in the state of Oregon. We have about 10 programs that can take parents with children, 10 residential programs. We used to have 12. COVID has dramatically impacted how treatment services are delivered. For a while, they were shut down completely. We had treatment programs doing no services. It took all of them a while to ramp up to do treatment by Teams or treatment by Zoom. And then our caseworkers and judges and legal parties to the case didn't have a lot of confidence in the treatment results because it was just so different. We didn't have face-to-face contact. We didn't have a lot of drug testing going on. We couldn't back up what the person said with what their behaviors were because we weren't seeing anybody. So COVID is really wreaked havoc, and we haven't recovered from that yet in terms of getting back to a really solid confidence in our treatment providers. And I would say the second thing is just we don't have enough treatment providers, and I think this is true across the country. There's so many areas of work shortage, and we have a desperate work shortage of alcohol and drug people. We've had several programs literally have to shut down completely and try to retool. And, we tried to add money to the system, but I had a, a longtime friend of mine who's a director at an adolescent program and said she was driving home, realizing she had to shut her program down for lack of staff. And she passed 3 fast food places, all of whom advertise hourly wages at more than their night staff, with $2,000 bonuses to start and free food tickets. And behavioral health is just way behind in that regard. And it's going to take quite a while for us to catch up. And again, we have long-standing relationships with our local treatment providers, but the more turnover we have, both on the child welfare side and those treatment programs, those relationships are what are key to really helping clients succeed in both of our systems. And when those relationships are impacted, the ability for parents to, even when they're doing really well, to be understood in both systems gets really challenging.
Thank you. I want to pick up on one of the last things you were saying, which is, these staffing issues are huge, and turn this over to Alice to talk about, what this means for the workforce development system, both for the customer side and the employer side.
Thanks. I was hoping you would pick me next because it's a good segue. Well, in Ohio, I've been working in the workforce development system for 36 years, and only until the last 5 years did we really start to address this as a state. Governor Kasich and then Governor DeWine have made this a priority for our workforce development system, as well as our mental health system, as well as our health department, all those other state agencies. But we always rank up in the top 4 in overdose death rates. We know that there's a high cost to this epidemic, and it's costing employers. We estimate that with health-related costs, emergency departments, courts, children's services, the cost to employers, it equals about the same as our investment in the K through 12 education system. It's about $8 billion. I always say 8 billion with a B, because it's a huge, huge cost that that we just got to address. So our children's services caseloads also are increasing and continue to increase because of this issue. And we also have lack of access to medication-assisted treatment. So what this does to the workforce development system, it brings us more individuals who have more complex and long-term challenges related to employment and training. We're used to a system that kind of is a quick fix. You get trained, you get a job, you place person in job, you're done. But this requires a much more long-term effort. And it brings people that have lack of work experience. Sometimes they're coming right out of a recovery home or a jail or other kinds of settings, and you just have to address the whole person. So we hadn't been used to that. You mentioned staff shortages. We are the workforce development system. So we're the people who are trying to create the pipeline for professions. So we do have a shortage of workforce professionals, and we're addressing that. We can't keep up with it, but especially in children's services as well as everywhere, courts, probation departments, treatment providers. So we're addressing that. And then this issue also reduces the workforce participation rate. A study at The Ohio State University estimated that practically all of Ohio's decline in workforce participation rate is due to opioid use disorder in particular, because people lose their jobs, maybe they've been injured, they never go back to work. So we've seen that. So the main challenges, I would say, is one, our workforce development system didn't have the experience working with this type of customer who has multiple needs across multiple systems. It's a challenge to get enough people interested in the professions like peer recovery support, chemical dependency counselor aide, social worker. So we're promoting those kinds of careers. And then lack of employers who understand this as a disease. And finally, stigma. It's just kind of like a foundational issue everywhere. Stigma really has to be addressed.
Thank you. All right, and then Chief Sepp, do you want to go ahead and talk about the criminal justice system?
Sure. Well, So how does substance use disorder impact our system? It pretty much takes up a lot of our time from the time someone is booked until they're released. I'm happy to say our jail here at Kitsap County Sheriff's Office is really proactive in the sense and progressive that we offer many reentry services, and I hope I can talk about those later. But the majority of the individuals that come into our facility are using drugs, and Washington State is, well, last year they ruled a Blake decision, which means essentially drugs are not illegal, or they're a misdemeanor after you've been caught with them 2 times. So essentially, there's no drug crimes, which is kind of a challenge for us. But so we're seeing an increase of that, and we're seeing an increase of arrest, not drug related, but these crimes are related to drugs, right? So you get property crimes, thefts of cars, and what have you. And these individuals come here and they test positive for opioids. And that is really strenuous on our medical staff and our corrections officers, because when somebody is withdrawing from that, we have to obviously monitor that, and it takes 3 times a day. And we get them withdrawn from the drugs, and then eventually we put them on our MAT program, medication assisted treatment program. You know, we talked about, someone mentioned it earlier about not having access to services. Well, I'm here to tell you, if you come to jail, you'll get access to services. If you have a jail that offers reentry services, it's sad to say that that's where you have to come to get it, but we offer the services that people need, and it's sad that we, as a society, we have to do that. But we put these individuals on our program, and they stay on it the whole time that they're there. It helps us in the sense that it gets them to court. It reduces recidivism. You know, before we started these programs, we captured a year's worth of incarcerated individuals, and 85% of them were recidivism candidates. So that's 85%. We've gotten down to 50%, which is a bonus, but 85% is terrible numbers, and that's why I'm a big proponent for saying spend the money now or spend it later. It doesn't matter. The money has to be spent. You know, we're going to talk about where funding comes from and what have you, but that's, you know, for us, the impacts is just caring for individuals that have been using drugs, and they have really bad medical issues, and it's strenuous on our medical staff and our corrections officers. As far as the main challenges for service delivery, we do a really good job here in the jail, I'm proud to say, but what's really, really difficult is the handoff. I've tried to fill gaps on that warm handoff to individuals, you know, and treatment providers that we have in the community, but we just don't have enough. And I think that's what we're talking about here is the common theme: not enough staff, not enough treatment providers. It's really helpful if an individual has someone there waiting for them at the door to walk them through transitioning from jail to the community, because it's not easy for them. You know, they've been incarcerated, they've been using drugs, they're making the right steps in the right direction, but they still need help. It's not ending once they hit the release door.
You know, I'm actually going to just let you go ahead and roll over into the next question, because I think there's a lot to say there about what you've been doing in the jail. So what approaches have you implemented to address these challenges, and how have you funded these efforts, and who are your partners?
Well, we have a very, very robust reentry program system here at the jail. We have several treatment providers that offer drug and alcohol assessments and inpatient and outpatient treatment, mental health treatment. We have child parent bonding treatment. We have DSHS that comes in here to help individuals who are back, you know, they owe back child support. So they come in here and help them, guide them through navigating the payment system and what have you, because people don't want to get a job because their wages are garnished. So we help them fix that problem. We have several programs that fit each individual, because I'm a true believer that not one size does not fit all. And the individual that's incarcerated should choose the path they want to take. And we have this great program called the Welcome Home Project. It is it's federally funded through Port Gamble tribe. We have 2 tribes in our county, and they've put together this great reentry program. They have some really good case managers. They call them success coaches, but they sit and walk them through the release process. They drive them to their court dates. They drive them to their appointments. They do healing circles, and it's a really good program, and they've had great success. So we try to fit, culturally what works for everyone. And we sit down with the individuals and we ask them, what do you want? Do you want to get on the MAP program? We'll put you on the MAP program, which is, again, medical assisted treatment. Do you want inpatient or outpatient treatment? Do you want housing? Housing, of course, is always going to be a barrier. We don't have enough housing to meet all of the needs of our individuals here, but I am working with legislators to help fix that problem. It won't happen overnight. But I'm going to sit and bang on the door of Olympia until I can get individuals, because I feel that you have to meet their basic needs before they can really focus on succeeding in their journey through, sobriety, if you will. How is all of this funded? It's all grant funded, and it's scary every year. Right now, I'm getting ready to write 4 grants for almost $2 million to fund these programs. And then there's a couple of my programs that come into the jail that are funded through the same 1/10 grant that we have here at the county. It's very scary every year because we never know if we're going to get the funding. And we're doing such good work, and we have the evidence and the support to show that it's working. It's just getting that money completely and not having to beg for it every year. That's the pressure point.
Thank you. Jay, I'm going to pose the same question to you. What approaches are you implementing, and how are you getting all the funding, and who's partnering with you?
I'm really fortunate. In the state of Oregon, people who came before me back in the early 90s put into the regular state budget money for positions for contracts. So we have contractors in the child welfare offices that are from the alcohol and drug field. So a caseworker walking around that building can go around the corner in a cubicle and say, can you help me with this? I've got somebody downstairs and they're about to do a visit, and I don't know if they're using or loaded or if they are on what. And most of those people are in recovery and can come down there and just kind of walk that caseworker through it, as well as be a much better option of engaging the particular parent. I mean, the parent is scared to death as it is for people to wrap your brain around what a horrific, terrible thing it is to walk into a government building. And in this particular building in child welfare, the second you walk in, you're identified as somebody who is such a train wreck that you can't parent your own children. There's more shame attached to that than anything I've ever seen. And we have people in recovery who have been there, who have done that, who've come out the other side. So we immediately can connect them with somebody who has been there, done that. And that's made a tremendous difference. All the recovery services that we have, just leaps and bounds over anybody with a doctorate or a master's or bachelor's degree when you can meet somebody that has been there and done that. So that's one of the things we have going for us, and we had that funding in our legislature for the last 30 years. We've enhanced it from time to time. We're just about to make another request because we've added 1 million people in the last 30 years. So there's a few more cases and a few more things we have to do. But we also look at every grant that comes our way, trying to do combination programs and more collaboration with different agencies to do these things, because our parents don't come in single packages. They come with domestic violence and mental health issues and SUD issues. And depending on their own histories of, all those ACEs that are in their past, they have to do quite a bit of work on their own as well. But I want to, what seems to get lost, and I'm really going to sound like the old guy here, is in every single one of our communities, we have 12-step programs that are free and available to people. And sometimes our professional folks get away from those programs. One of the best things we do, and we've researched this, is, when we don't have recidivism, it's generally speaking that we've done a combination of getting people into treatment, which is what our services do, and then linking people to the local 12-step programs. And 12-step programs are not for everybody, but there's a bigger variety of self-help programs than there ever have been. And hearing the old guard just be in wonder at how effective recovery apps are on people's phones. And, you know, we have so many apps on our phones for all those things that we like and enjoy and think are entertainment. But having in your pocket at any time a direct connection to another person in recovery is just underutilized. We have to do that much better. And like I say, we work with the courts, we work with our family treatment court system, we're working with any money that comes to juvenile justice and family justice to try to do those combination things. So it's always a search for money. But underneath that is a search for a true collaboration. You have to really have links to people, and people that can make decisions have to continue to go to those meetings. They can't delegate it. And when we have that collaboration, the money flows better.
Thank you. All right. Alice, what are your thoughts?
Some of the similar kinds of things, but as a workforce development system, we are funded by the U.S. Department of Labor, and most employment and training programs by the U.S. Department of Labor are implemented through local groupings of counties called workforce development boards and workforce development areas. So we as a state, our approach was to seek funding from the U.S. Department of Labor to develop a whole new way of working with individuals with substance use disorder. So the first thing we did was develop a toolkit for helping individuals impacted by substance use disorder, specifically for workforce development professionals. We built that around 5 pillars of success. The first is partnerships, which was just mentioned. We can't do this alone, and we haven't had strong partnerships across the board in the state prior to some of these grants. So we're employment and training professionals. We depend upon our partnerships to provide a lot of the other services that treat people holistically. And so I guess that leads to the second pillar, which is we've developed a brand new service delivery model, which we call holistic care management, as opposed to case management. We are working across systems to manage people and their progress toward individual goals, and whether it's family reunification or probation requirements. So we have a way of measuring that, and we encourage people to have cross-system care management meetings and see when they're ready for employment or when they're ready for training, or if they're meeting their family reunification goals, because we know they have to be addressed comprehensively. And then the other thing that's one of our pillars is engaging recovery-friendly workplaces. It doesn't help us if we place people, but then they're at an employer who fires them the first time there's any kind of an issue or they test positive. We want to engage employers that understand the disease and know that that's a part of the process. So helping them to keep those jobs. And then the fifth pillar is building knowledgeable staff. We've trained every single one of our staff in our Office of Workforce Development that deals directly with job seekers and employers. And we've also trained everyone in our American Job Centers, which is, again, the county level agency that delivers these employment and training programs. We've trained all of them in substance use disorder as a brain disease, taught them stigma-free language, and it was just eye-opening how much of a difference that made in people's attitudes about serving this population. We have gotten 4 grants from the Department of Labor specific to this. And so we not only are treating individuals in recovery, we're also building the professions like social work, like peer recovery support. We're developing those employers that are recovery friendly. And our partners are just dozens and dozens in every county. So we have, of course, the local workforce development boards, we have courts, we have children's services agencies, we have probation departments, mental health boards, education and training providers that are providing the skill training. And I think one of the most important ones that we've had is a subject matter expert on recovery-friendly workplaces.
So you've brought up a lot of good points about cross-system issues through case management, through partnerships. So I'm gonna actually, Alice, let you roll that into the next answer to our next question, which is, what challenges have you faced working across systems? What advice would you share on engaging in cross-system efforts to address substance use?
Well, as I mentioned, I think we found that we should have started with stigma. We should have started with educating our staff to become knowledgeable about substance use disorder as a disease. It was so eye-opening to hear people's comments about understanding that this disease is just like heart disease, it's just like diabetes, it's just like asthma. You can expect that there may be relapses, and relapses simply mean that you need to adjust treatment and you need to kind of change course or tweak the course. I think the second challenge that we've had is competing expectations. We found, I think this was true of a national study of some opioid grant pilot programs, that workforce development's expectations are kind of get them in, get them placed, and you're done. But the treatment professionals, they understand this is a long-term disease. It's a long-term effort required. So understanding the performance outcomes that are required by the Department of Labor, and when people are ready for certain aspects of services, like whether they're ready for training or whether they're ready for a job, and starting out more slowly with some work experience kinds of things. And then I think another challenge has been that we have competing expectations of our participants and our customers. So a probation department may want to meet with someone during the day, but it's competing with our goal to get someone employed and to be employed full time. So really working through those kinds of issues is important. And then all of our systems are just complex. Any one of them is so complex. So we are in many places using employment navigators to help people manage their way through getting on Medicaid, getting child support payments arranged, getting housing, getting to a place where they're ready for training or a job. So navigators are really important. I think Jay mentioned peer recovery supporters are a key part of that. And that's a really effective method that we're using not only in children's services, but with courts and with various other partners. So, and then I think finally, a key would be identifying and promoting champions, because not everybody has bought into this real strong initiative to take on a more challenging clientele. But we've got some amazing champions that have done amazing work, and just touting their work and showing them as models. And again, that's a peer-to-peer kind of a training that is more effective for the other workforce development professionals to be training their peers than sometimes it is for us as state staff members to do so.
Thank you.
Mm-hmm.
Chief Sepp, could you talk about how this plays out in the criminal justice system, challenges working across systems, and advice on engaging those kinds of efforts?
Well, immediately, Alice brought up a good point, and it's, we talk about stigma. So for the jail, from the get-go, the first thing we had to do was change the culture of our jail and the staff, going from punitive to restorative, right? So if we're going to have all of these programs in our jail, and individuals from these treatment providers coming in and asking for officers to pull individuals out of the cells and what have you, we really had to sit down with the corrections officers and tell them what our plan was and why, because they always want to know why, and get the buy-in from them. It took a while. I'm not going to lie, especially with the MAT program, because some people were really supportive. Most of them were, but there were a few naysayers. And often it didn't help when someone was on our program that they got released and came back. That was kind of a reinforcement for those naysayers that it doesn't work. But as we all know, that it takes for some a couple of times to get it right. Eventually, what was new to them is the norm now, and now I hear officers constantly referring patients to the MAP program because now they embrace it. They embrace the reentry. We celebrate our successes. One thing in corrections that we do not see is we don't see the positive. All we book people, they get released, and then we always remember the ones coming back. So we don't get to celebrate the successes. And so what I do is try to provide those success stories to the staff to show them the good work that they are doing. And with the cross systems, I expect all of the treatment providers to have that same philosophy if they're going to come into the jail and provide the incarcerated individuals here services. You don't give up on somebody the first time or the second time or the third time. You have to keep working on them because it might take a few times. If they're going to give up on them, then I'll find another treatment provider that won't, because one of my pet peeves is finding individuals that live in our community that have been, they're not allowed to go to certain sites or certain treatment providers because they don't behave well, is the most politically correct way to say it. And that kind of infuriates me in a sense, is like, where are these individuals supposed to go? So we've been tapping into some really good programs out in the community because our county is really progressive as well. And we've got individuals out there who are peer, who have been there, done that, and they go out and do outreach to individuals that don't fit the mold of all the other treatment providers. So it is difficult in the sense that we have so many in the jail, and sometimes I feel like they are competing in a sense. Some of them are grant driven, so they kind of overlap. So we have to sit down with them and make sure we're all on the same page, because sometimes it feels like two people are doing the same thing, and that's just a waste of resources when we have 400 people incarcerated here that need help. So it's just trying to wrangle them all and assure them there's plenty of business for them, because unfortunately, when these programs are grant driven, they're data driven, they're success story driven, and that's all they can think about is numbers. Where if I get one success, it's a success. If we save one life, if we hand out one Narcan kit to one MAT participant and they get released and they use drugs, but that Narcan kit saves them, it's a success. That's how I look at it.
Jay, do you want to go next? What challenges have you faced working across systems, and what advice do you have?
Well, I think all of us face that challenge that we talked about, the bias and the stigma that, and I do believe it should be taken on first, because people don't even have an understanding of their own bias until they, are face to face with somebody who has lied to them for the past 6 weeks about use, and then they got a UA that showed they were using, and the person says, I can't believe they did that to me. It's like, well, they didn't actually do that to you. You're not quite that important. They have a chronic illness. So, get off your pedestal. It's not about you. It's about the illness they have. And so that's always, it's a maintenance, ongoing training thing. And we're never going to have enough of that. And the other thing I would just say is we have to celebrate recovery every time it happens, because people have to understand that all these trainings they go to about bias and stigma really pay off. And when you have, frontline officers or frontline CPS workers or people that are only working in a place where, give me the new person who needs a job, you start to think, does anybody get better? And there's recovery everywhere. I mean, it's amazing how many people are in recovery and they don't hang out at the sheriff's office anymore. They don't hang out at the jail welfare office anymore. They're out there in the community doing all the things that we want to do. So getting our workforce face to face with what recovery is, and that it's present every day, is really important. I think the across systems challenges are, you have to have, real commitments versus paper commitments. You'll get together, you'll sign a bunch of paperwork. People said, oh yes, the judge says, yeah, we're in. And, the executive director says we're in. And then all of a sudden I can't get somebody into the treatment program. And the executive director says, oh, here's how we do it. And my line staff are saying, you clearly don't work in your intake department. You have no idea what's going on in your intake department. So that collaboration has to be a real transparent and rigorously honest kind of engagement, because systems break down if the only people talking to each other are administrators that really don't do the work. You've got to have collaboration at the line staff level to really pull things off. Everybody has their own kind of focus, whether it's I need people to be employed. I have to watch out for public safety. I have to watch out for child safety. And a real collaboration recognizes all that. So when I see collaborations kind of get real bumpy is when somebody says, my cause is bigger than your cause. It's just like that. We got to tamp that stuff down and really, again, have community focused. We're really trying to make our community better. You have to understand my charge a little bit. I have to understand yours. And again, to me, it's training to compassion. And that's what the stigma and bias part speaks to. But if you understand that, and people you went to high school with, your cousins, your former classmates, the ones that you haven't seen since 7th grade because they dropped out because they were starting to use when they were 12 and you didn't, those are the people we're trying to help. Those people that you were in 1st grade with, but you never made it to a senior year in high school with, those are the people that need our assistance. And just because they have this illness doesn't mean you're going to exit them from the community. They're going to be in our community. So, embrace them. You don't have to embrace all their behaviors. You don't necessarily need to move them into your basement, but you have to embrace the people in your community. And when you understand the illness of addiction, that happens. I think when people truly get how addiction works, it's like, wow, this is a killer. And I recall when meth labs were going crazy 20 years ago, there was a law enforcement officer in Eastern Oregon, and he was kind of a lock him up and throw away the key guy. And then his wife became addicted. And he wrote an article saying, I had no idea it was happening in my house. And I did every single thing possible. And she couldn't stop that. And now I get it. That's what I'm dealing with in my community. And it takes those personalized kinds of conversations with people to say, you got to get rid of the anger, you got to get rid of the frustration, you got to learn to handle that on your own. That's part of working with people that have chronic illnesses, whether it's heart disease or addiction. It gets really frustrating, but train to the compassion.
Well, that's our last moderated discussion question, but that is a great segue to the first question in our Q&A box. I would invite everybody to enter any more questions from the audience that you have in the Q&A box, but we have a great first one to start us off. The question is, it seems like stigma is a major challenge for each of your systems. Do you have strategies like media, trusted messengers, success stories, or strategic alliances that you have found to be successful in reducing and reversing stigma? So I know we've started to talk about this in answering the last question, but want to open that up to the panel. Thoughts on strategies for addressing and reducing and reversing stigma?
I'll just jump in with a general one, and I know that there's some specific ones that the other panelists have talked about, but it's not only training to the concept of stigma and bias so that people start to recognize what there is, but I mean, I'm flooding people all the time. We got about 1,700 caseworkers. I send 1 million emails out because everybody's a little bit different in how they're going to hear that. Some hear it from personal stories. I send stories out about recovering athletes because there's a bunch of people that follow the NBA and the NFL and they have no idea. When you got Terry Bradshaw won a bunch of Super Bowls saying I was ready to kill myself after the second one, it's like, what? It's like understanding mental illness and depression through something that you're very tied to and interested and connected to. So you use whatever tools are available to get people to understand how many people this affects and how many people have come through the other side so that you can go to work every day knowing that people really can come through the other side. So it's like having a bunch of tools in your toolbox to get people to find that personal interest that says, okay, I'm in now. I get it now.
And I'll jump in, and I touched on it earlier about starting with my staff, and I think they are probably now some of my trusted messengers. But really having Sheriff Giese out there talking about, at one hand talking about the high crime rates and how because his community wants people arrested because they're out stealing cars, but on the other hand, telling everybody what these great programs that we have to help individuals, because we all realize that when you peel the layer of the onion and you find out why individuals are, for the most part, committing these crimes, it comes down to not only drugs, it comes down to childhood trauma. We really focus on trauma-informed care so that our staff realize that people just don't wake up one day and want to be use drugs or be mentally ill. You just don't wake up mentally ill. That happens, right? So it's just really reinforcing that in your culture, having your leaders like our commissioners, they go out there, they support all of these programs. They support it to the fact that they're They're paying $2 million a year for the jail programs in our facilities. So there are trusted messengers, but the biggest ones are the individuals who have succeeded through our programs. We are always getting emails. They are always walking the streets of this community talking about how the jail saved their lives, how the jail redirected them. They're out there working in these treatment programs as peer supporters, and they are telling their story to individuals that are in our facility now to show them that this is going to work. So I think it's just a community effort. Everyone has to keep doing the good work, and there's nothing better for me, I think, than hearing somebody that's wearing a badge, supporting individuals, helping them get the services they need so they can get back on track.
I want to add a couple of really kind of small, but I think really important pieces to the addressing stigma. One, I already talked about, we trained all of our staff, and just how amazing that was, and eye-opening, because again, it kind of starts with your own perception of why people are behaving the way they are, and understanding this is a disease, this is a symptom of a disease. But another thing that our Department of Mental Health and Addiction Services has just done is sent out information to all the media people about words to use and words not to use, because I think, again, this was part of our training. This was one of the first things I did when I started working in this arena, was you've got to use destigmatizing language, because people hear it. People hear it when, you know, you're those people, or, you know, you use terms that are degrading and non-respecting of that person. We started a media campaign with lots of different ads entitled Your Path to Employment During Recovery, because a lot of people don't see those two things happening hand in hand. Recovery is possible and employment is possible. And then normalizing the fact that we know that this is an issue everywhere. Everybody knows someone that's impacted by substance use disorder. So I think some of the effective practices that we've seen in our Ohio Means Job Center is that every single orientation to every program that they bring a group of potential participants into, they talk about the fact that everybody knows somebody. We have special funds to address the opioid use disorder emergency, or substance use disorder emergency, and just normalizing it. We expect it. It's not unexpected. It's not, oh, you know, it's a surprise. It's expected. We know people either have substance use disorder themselves or know someone, so we talk about it. We put it on our screens in our computer labs where people are searching for jobs, so that they know, oh, if I have an issue and I need some additional services that these grants can provide me because of my history of opioid use or substance use, or a family member or a friend, I have them right here, and we talk about it out in the open.
Thank you. We have another really interesting question. Has there been discussion on different agencies using similar platforms, data systems, to help make sure everyone is on the same page when dealing with a participant or client? I think we have a lot of researchers in the audience who are probably interested in the answer to this as well.
I'm going to jump in there and say that I would love to have that program, but I can't get past everybody's attorneys to agree on an ROI. So that has been our biggest hurdle. I capture my own data the best I can. You know, we know our participants that are on our program and whether they come back to our facility, but that's all I can capture. I can't reach out to Kitsap Mental Health Services or West Sound Treatment and ask them how anyone's doing because of HIPAA and what have you. So I'm kind of stuck there.
I would agree. It was one of the things I was referencing before about true collaboration. And I think there's some of those system issues that, quite frankly, legislative action would be required to fix. They're so rooted in protection, and I'm not against protection, but I've been in the A&D field for over 40 years, and I have watched what I would call the red light people when we go to a treatment program and say, well, we'd really like to know. It's like, oh, no, 42 CFR, 42 CFR. And 42 CFR becomes like this impenetrable wall from a science fiction movie. It's like, you can't, it's like, well, no, if you look at the law, it says, here's what you protect. And then complete with that are how to build the bridge. Like, this is how you share. This is what you put in place. And so it takes people that are green light people to say, okay, how under 42 CFR do we move information? How under HIPAA do we move information? What kind of information can we move? But we get so caught up in our revenue streams requirements about individual outcomes, and we don't have revenue stream requirements that have the authority to get collaborative information very well. They say you got to work with other people, but they don't have the authority to say, I'm going to give you money, sheriff. I'm going to give you money, child welfare. And you have to come up with this data, because they don't have the authority to change those data systems. So it's a real challenge. That's always the case, which is why you have to hang on to the anecdotal stories, because it's really hard to get universal data.
Alice, do you?
I will say that from the U.S. Department of Labor's perspective, we've tried that with other programs like adult basic education programs and Department of Developmental Disabilities and various other entities that are all related to getting people trained and put into jobs. And it's a monumental undertaking for them, and that was primarily to measure outcomes. Like, are they employed? Are they employed second quarter and fourth quarter after they exit our programs? How much are they making? So that was the primary purpose for those kinds of data commonalities. But Congress determines that for us. So it's I don't think from a individual perspective, it would take a lot to do that. So again, I think maybe studies would be helpful in that regard, but in terms of just having a database that falls in your lap, I have my doubts about whether that would ever happen. It hasn't in my 36 years. So even though we know it would be a great idea.
I would. I'm not seeing any audience questions right now. I'd encourage people to type them in, and we're happy to answer them. I want to follow up on that last point you made. You said that research would be helpful and studies would be helpful. I think researchers in the audience are always interested in what can we do to actually be helpful. What are the questions that you have on your minds? What is the evidence that would help you move your work forward?
It would be interesting. When you think about the research, you're looking at, these are the individuals in the system, and what did the system do with those people, and what was the end result? And, this presentation today has people from 3 different areas. So research on the ginormous gaps that exist in trying to track an individual person who's in all 3 of those systems. Because part of it is better services, more collaboration. But if you're going to build revenue streams on data, you have to have that. So that really old bias is rooted in the truth that when we shared from the A&D field what was going on with individual clients, they paid a terrible price. And so the whole field just jumped back under 42 CFR. I mean, I remember people coming home post-Vietnam, and this is just when my career started. We were still having, law enforcement camping out outside of treatment programs, seeing who was coming out of the door, knowing they were the folks doing the drugs and arresting them, and then walking in the door and getting the records. I mean, really, that was when the Nixon administration, everybody hold their breath. The Nixon administration did a good thing. Yes, they did 42 CFR, which protected people and allowed them to go to treatment and have their records protected. But that was a long time ago. And so, we haven't evolved as a system to say, how do we still protect the individual, but make sure that all the money we're putting into the system to get somebody a job, keep them out of the public jail system, and keep their kids safe, really effectively is collaborative when we can't even talk about what happens to each other. That's a research project to show the shortcomings of that.
Other thoughts on?
Well,
research?
I agree. I think it would be a study where you would capture a few participants, 10, 15, from the start of their incarceration through their treatment and where they are. So kind of like a long time frame. would be good. So, because we do struggle with having the evidence to support these grants, what we can gather as far as data is good, but it's not good enough. And I think, we talked about those success stories are really powerful. I'm sure the numbers would be, but until we can figure out how to navigate that and get us all working together, it's just really following people for a long period of time and seeing how they progress and succeed, or whether they don't succeed and why, because I think that's where we need to start filling in those gaps of where people fall off and maybe go back into the lifestyle that they had before.
I have a really good suggestion for a database that would be useful to track people that have entered, one or more of all of our systems, which is the unemployment insurance wage record database, because every single person who's employed in a covered employer who pays into unemployment records the earnings every single quarter. So that would be an easy way to track them on the other end. If you can, figure out how they cross across these systems, then easily track them at the end for a long term.
And so it's back to being all about the data linkages. All right. I'm not seeing any more audience questions. I'll give it another minute or so for them to come in. While I'm waiting for any more audience questions, I do want to just echo Lauren and encourage everybody to sign up for the NARS mailing list or follow NARS on Twitter. This is the first of our virtual conference workshops, and we have a whole summer of virtual conference workshops planned. So please, stay tuned for that. Keep in touch. We're always interested in crafting these so that they're responsive to, what's on everybody's mind. Things like addressing substance use disorder, childcare, impacts of COVID. These are all the things we're going to be talking about all summer. Okay, I'm not seeing any more audience questions, so I think I want to just give our panelists a huge thank you. This has been very informative, very helpful, and we appreciate your time and your expertise. And we can give everybody a little bit more time back in their days to think this all over. So thank you very much, everybody, for joining, and enjoy the rest of your day.
Thank you.